We are recording this, just so you know. Hopefully that's not an issue, but there's some folks that wanted to attend that couldn't be here, so we'd like to be able to make it available to them afterwards. Just to remind you, so the folks we have with us today are AOT monitors. If you're not a monitor, you're welcome to observe, but we really want to keep the conversation focused on issues of interest to this specific group. So these are our folks who primarily act as the liaisons between their mental health systems and their courts and their providers. And kind of keep things moving. We kind of like to think of you all as sort of the glue that holds the program together. So we really want to focus today on issues that you all might be encountering, that you want to maybe troubleshoot, if you've got some challenges, that sort of thing. What we thought we would do, well, I think at this point, most of you know Amy and I, but I'll just introduce myself quickly. So I'm Betsy Johnson. I'm one of three on our implementation team. I wear the advocate / kind of family member hat on our team. Amy, I'll let Amy introduce herself. And then what we thought we would do is just go around the room, ask each of you to quickly introduce yourself, what your role is with the program. And then if you have an issue that you would like to talk about today, if you have a challenge that you're facing or, something exciting you want to share that you're doing, some kind of outside the box sort of thinking that you think others might benefit from, if you could just introduce that briefly when you introduce yourself, and then we'll see if we, identify some themes so that we can kind of bring that up for discussion after the introduction. So we'll kind of be keeping track of that. Amy, if you want to introduce yourself, and then we can go through the list here.
Hi, I'm Amy Lukes. I am the second part of the implementation team at TAC, and I'm a social worker by training. I want to also ask you to share your jurisdiction or where you're coming from, where your program is located. So we can see well, just because it's interesting. So I'm going to go ahead and call you out now. So Betsy is nicer than I am. So I was going to put you all on the spot and say, we wanted you to name one challenge that you're having as part of your introduction. But Betsy is nicer and says, if you have a challenge, let us know. So either way, again, as I said earlier, we really appreciate if you use your cameras because we are trying to build a community here. So I'm going to go ahead and I'll call you out as you are on the Hollywood Squares. So Judy, you're first.
Hi, I'm Judy Dahlstrom, and I am in the Gastonia, North Carolina area. We are serving 6 counties with our grant, and I work for Partners, Behavioral Health Management. And we do have challenges. We are new to the grant, of course, started in August, and we're having some issues trying to figure out our place with the court system and the hospitals in a court that kind of sees OPCs as a 90-day issue, and trying to get the mindset changed for that.
Thank you. Erica.
I am Erica Von Lowe, I'm the court liaison here in Bexar County, and we're having a lot of success lately, but we are having challenges as well. One of our continued challenges, and we've made a lot of headway with certain hospitals here in our county, but we also have got a few where we're just continuing to have to work on, appropriate referrals for AOT, kind of understanding the time that's needed to take in a referral, get them screened and assessed, and sticking to that process. We have hospitals sometimes who will jump to, sending in the paperwork to the court before we're getting a chance to screen. So I think it's kind of, we're balancing those challenges. We have seen a lot of improvement, but we're continuing to need to work on that.
Thank you. Melissa.
I'm Melissa Keel. I'm in Genesee County, Michigan, AOT monitor, and I'm still pretty new. I've only got a few months in, so a lot of my challenges are learning the job and learning about the program. So
Glad to have you here. As I say, you're new. You're a new face. Glad to have you. Welcome. Laura.
Hi, everybody. I'm Laura Braun. I'm the program manager for the AOT program in Bernalillo County in Albuquerque, New Mexico. I sometimes wear the hat of AOT monitor. I would say one of the challenges that we're having is we are transitioning treatment providers, and it has not been seamless. So we're currently in a gap right now and trying to ensure our individuals maintain a level of service. So that's our current struggle, but nice to be here.
Nick.
Hello, I'm Nick Schrantz from Butler County, Ohio. We are the county north of Cincinnati. I've been the AOT monitor here in Butler County for 14 years. My biggest challenge in this established program is it's not connecting probate respondents to treatment. It's how quickly we can assist them when they refuse the treatment that's offered to them. And we can work on court orders. We have an active and efficient crisis team. All of those things are available, but as you all know, there's that fine line between day one when someone refuses meds or refuses a long-acting injection and the time in which you can either call the crisis team and they might be qualified for an involuntary hold, or trying to utilize a court order before they display such symptomology because you don't want them to further damage their brains as they decompensate. So that's the biggest issue we face, and I don't think there's certainly no easy answer to forced medications in the community, but I think it's a very real question that we deal with all the time when we're talking about assisted outpatient treatment.
That's a really interesting topic. And for those of you who aren't aware, we have Nick to thank for this meeting. Years ago, which seems like, it seems like an eon, but Nick and one of his colleagues from another county in Ohio suggested that AOT monitors meet to do a number of things. But so thank you, Nick. Ariel.
Hi, I'm Ariel Edwards with Lorain County, Ohio. I work with the Mental Health Addiction and Recovery Services Board, but one of my many hats is the AOT monitor. So I think a couple people have already mentioned some of the ones I would say, some of the referral process, cleaning that up. And for me as a new-ish monitor, I guess one of my challenges is what's the best system for monitoring? Like from beginning to end, what are some of the things that make it easier? Some of the, you know what I mean? Some of those systematic type things that would make it easier to bring all those partners together to make sure the monitoring is done on my end correctly. And then the other thing I would say is kind of going off of Nick, but a little bit more actually after the initial probate is some of the compliance issues, or like how to encourage or keep people interested in the AOT program, knowing we really don't have some of the same teeth like a criminal court would have. We faced a few people who just, why am I here? So trying to keep them encouraged for their benefit without losing them.
Yeah, that everybody struggles with that. Beth.
Hi there, Beth McMinn-Sullivan, Summit County Probate Court in Ohio, AOT monitor, New Day Court coordinator, blah, 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 blah. And I think one of the things, I can relate to what Nick and Ariel are both saying as well. And one of the things that I'm finding difficult is getting the case managers to get their people to court I know they're short-staffed and, there are all kind of issues like that do come up, but I've noticed recently it seems to be we're getting a lot more no-shows than usual. So I would really like to, I don't want to step on toes because I just don't want to do that, but they need to get them here. They need to start getting them to court. And that's kind of what I'm seeing going on right now. And the second thing is we're starting to work on coming up with a plan where we can catch the folks that are incarcerated now for minor.
Beth, I think we're losing you. I'm sorry. We're going to go on and we can come back to you at the end.
Ursula?
Hi, Ursula Davis. I am the AOT monitor for Orleans Parish AOT program. And right now, I'm not having a lot of issues. I think the coordination of care is working really well. We work with a few ACT teams, and because we are able to stick with the same ACT team, it's been working really well for us. So I don't have any issues. We had more issues with some of the laws in Louisiana, but some changes occurred. So right now I'm not having any real issues with the program.
Excellent. And welcome. You are also a new face.
Yes.
Belle.
Hi, everyone. I'm Belle Cadena. I'm here in Albuquerque, New Mexico. I'm the program specialist and the grant. I do grant oversight. I also work with Laura. Some of our challenges, as she mentioned, are that we are in the process of solidifying a new provider. And so just kind of making sure that everyone's taken care of, in particular our clients.
Thank you. I cannot imagine going through what you all are. Heather Currents.
Hi, I'm Heather Currents, and I'm a program coordinator at a mental health agency in Fairfield County, Ohio. I see the AOT monitor, and he couldn't be here today. I guess one of the struggles that we're having is we used to have a psychiatric unit in county, and that has shut down. So it's a challenge working with county hospitals to get Fairfield County residents in our program.
Tara Ray.
Hi, my name is Tara. I am a psychologist by training, but currently I'm a quality improvement specialist at King County here in Seattle. So I apologize, it's lunchtime for me, so I am eating my lunch. So I'm happy to be here. I work closely with our AOT liaison who's not able to be here today. So I'm just really interested in hearing other people's perspectives. One of the biggest challenges we're having here in King County is we have a lot of different providers that offer AOT, and there's just a real lack of communication between the providers and the court system. And us as the county, we're trying to help facilitate that. But the reality is that agencies are not really incentivized to take the AOT clients. And unfortunately, a lot of people fall through the cracks. So part of my role is to observe what's going on and hopefully help with improvement.
Oh, that's great. Thank you for joining us. Todd.
Hi, everyone. My name is Todd Chambers. I am part of the AOT team in Gastonia, North Carolina for Partners Health Management. And we are actually joining because we're possibly interested in coordinating some type of AOT monitor ourselves. But I share a lot of some of the same concerns that I've heard so far today. But one of our main issues that we're having is cultivating that relationship with the courts to where this whole AOT process and the continuation or extension of outpatient commitment is more of a, let's say, community involvement, more so than just coercive in its efforts, and really getting the judges on board to understand the importance of that and continuing that communication to encourage members to stay active on the working with the AOT program. So that's kind of some of the issues we've been dealing with.
Thanks, Todd. Michael.
Hey, I'm Michael Van Cleve in Athens, Hocking, and Benton counties, Ohio. AOT monitor right now, working on developing programs in those 3 counties. At the moment, just communication between stakeholders has kind of been our biggest barrier, but I think things are looking promising now. So.
Excellent. Brianna.
Hi, I am the AOT Family Client Advocate is my title here in Wood County. We just started getting our program going, like for real this time. So it's been in the works for a little while, but this is the first referral that we've gotten. And so I guess the biggest challenge that we're facing is that we're a baby program. And so just making sure that we are working out all our kinks and taking in as much information as I can to make sure that I'm helping the process go smoothly.
First client, thumbs up, way to go. Sarah.
Sorry, I was muted. Sarah Taylor, Tarrant County, assisted outpatient treatment. That's next to Fort Worth. I am currently and have been since our grant ended 5 different people, including the monitor. So our biggest challenge right now is just getting appropriate referrals from our hospital. Unfortunately, we continue to receive patients who have extensive substance abuse use or extensive medical issues that we're not able to monitor and provide the services that they need. Court is going fairly well. We were meeting every other week prior to COVID. We're still meeting once a month over telehealth measures. Our courts have still not opened up here yet. So that's anticipated within the next few months. So we'll see how that goes.
Thank you. Mari.
Hello, Mari Tejas from County in New Mexico. One of the biggest challenges that we very recently overcame is we lost our district attorney. And so we had to go through an entire process of hiring another law firm, getting them trained, and we finally got them on board. But in the meantime, we did have to stop accepting clients for a little while, and that was very difficult.
Janet.
Hi, Amy. Hi, everybody. Janet Hayes in New Orleans Parish. I work with Ursula, also the wearer of many hats. Last year, because of COVID, we lost our city funds to be able to employ Ursula as AOT monitor. So I stepped in the interim to assist. So we have actually, as Ursula said, we have a great collaborative team. Our problem was we had a law with a lot of barriers preventing interested parties from being able to apply for services coming in from the community. So 2 outstanding barriers that the law required the interested party to have medical documentations or documentation like the evaluation, a patient's evaluation and a detailed treatment plan in order to file a petition. And also in our parish, in our state, our law requires written concurrence from the coroner, which I won't get into that, but Louisiana uses coroners extensively in emergency. And so our coroner decided that she did not want to participate in AOT for, I think, reasons that are partly legitimate. And so that also prevented interested parties from being able to petition. So meanwhile, the hospital wasn't referring people into the program either. So we went through a dry spell We changed the law. We rewrote the whole law. It was passed this session, and now it's very easy to file a petition. And so since then, we've seen a huge uptake. I have 3 right now that I'm just talking on the phone. So my role is now to get people into court, or my role is to get petitions going, and then takes over from there. So I'm essentially I'm working at the we're 2 ends of the same coin. So I get people into the program, and Ursula monitors them.
Thank you.
As well as the services to make sure the services are being delivered. So, and I'm going to have to bounce off in a few minutes because I have another meeting, but I just wanted to stop in and say hi to everybody.
Thank you. Kayla.
I was on mute. Yeah, I'm from Springfield, Illinois, Sangamon County. And I just started as the program coordinator a couple weeks ago. So I am still trying to learn all the ins and outs of everything. But I do feel like the most challenging thing that I've noticed is getting also appropriate referrals, and then also having the collaborative team that gets everything together. So like the guardianship attorneys, all of them being on board with the specific clients that we are trying to work with. So it's definitely a challenge that I'm walking into. However, we do have 11 active clients right now, so that's exciting.
Wow, that's good.
Yeah. So still trying to figure it all out, but I like it so far, and I think it's going to be a great program. So
great, thank you.
You're welcome.
Betsy, you've been studiously taking notes.
I have, and I see a few themes here, so I'll just share what I have observed, and if you picked up something different, let me know. But a few themes: transitioning of AOT partners. I've heard district attorneys, providers. I know that here in Ohio we've had a lot of judge turnover. So just how do we work when an existing partner who's been working really well with us moves on, and you have to replace them with a new partner? If anybody, maybe we can have some discussion about ways that folks have been able to successfully navigate that. Another theme, appropriate referrals. We've got some ideas around this one. We had a long conversation with our friends in El Paso yesterday that are really struggling with this issue. So we have a few ideas of that ourselves, but wondered how folks are making sure that they're not having to turn folks away if they can avoid it. Intervening early when somebody is starting to decompensate, and how do you keep participants motivated? And then also cultivating relationships with some of your system partners. What are ideas folks have around those things? I think those were my big themes. So I guess, go ahead, Amy.
Go ahead. No, go ahead.
I was just curious, if somebody has run up against one of those challenges and has had some success navigating it, we'd love to hear from you. I think we can just, any one of those, we can just kind of put out there and kind of get the conversation rolling.
And there's no need to raise your hand or anything, just unmute yourself and jump right in. It's a casual group.
I just wanted, before I leave, and I'll leave you guys with Ursula, we are having a problem with wrong referrals. Also, they're being referred, they're eligible, but really some of these folks need long-term institutional care. AOT is not really appropriate, and I think a part of that is doctors see AOT as a solution for the worst of the worst, as opposed to people who can do well in the program when they're just with medication and can live safely on their own under supervision. The doctors just don't want to refer people that are saying, okay, doc, I'll take my meds and go to my outpatient clinic. And they keep coming back over and over and over again. And their reason for that was they don't want to destroy rapport with the patient. But, we all know that you're not doing yourself any favors by requiring someone to keep coming back to you over and over and over, rather than placing them in a program that's actually going to help them. So hopefully we can deal with that problem.
Yeah.
And that was kind of a conversation we had yesterday. And another problem with that is, if you're turning folks, so if a doctor or somebody's making a referral and you keep turning them down because they're making inappropriate referrals, they may just throw their hands up and say, oh, I tried this program. They won't accept any of my referrals. I'm not going to do this anymore. So it might be time, if that's an issue that you're dealing with, you might want to go back and revisit your program criteria. Maybe you need to fine tune it, be more specific in terms of who's appropriate and who's not. It's not like you're turning the individual away from the program. You're just saying, oh, I'm sorry, but this person doesn't meet criteria. This is the criteria. And the conversation we had yesterday is they have one set of criteria that works well for the hospital, but then their jail is starting to refer people. So people are coming out of jail, but they really need that extra support. So they want to refer them to AOT, but they're really not appropriate. So, or they have no housing, and the program doesn't have the ability to house people. So they're really just looking to use AOT as a way to get people. They thought that would be one way to get some of these folks into housing. So, it's okay to have different criteria for different referral sources. If one of your criteria for the jail has to be, they have to have some sort of housing, you can just decide what that looks like. It could be a group home, it could be a, secure housing, whatever, but that might be one way to help with that issue. I wonder if other folks have dealt with this and successfully or.
This is Judy. This is probably oversimplified, and I apologize if I'm insulting everybody's intelligence by offering this, but we had a few inappropriate referrals, and we have a little 2-page referral form that is emailed to us. At the top of the page, we just put the 5 criteria with a check mark beside it. So when they fill out the referral form, they're able to see the criteria. And it sounds very simple, but it seems to be helping a little bit. So it's like I said, very simple.
We do have examples of different referral forms on our website, but if you have a good referral form that you're especially proud of, we'd love it if you would email it to us so we can share it with others.
So I know one of the things that we've been doing here in Bexar County is, we get a lot of folks with the primary diagnosis that we need, right? The schizoaffective or schizophrenia, and the secondary diagnosis of substance use. And at the time, if we haven't interfaced with that client, like we don't know how bad the substance use issue is. And sometimes, you don't find that out until you're working with the client. You're getting to know them and the issues that are coming up. And so, one of the things that, at least this is sort of the perspective that I've taken when those things start to happen and like substance abuse then becomes primary, we work at trying to get them connected to the resources that they're needing at that time, whether it's rehab treatment. And we just had a client who we took on who has a really bad meth problem. We did not realize that was primary when we took her on, because these assessments are coming in so quickly and we're turning them around really fast. And we were able to actually, with her permission, make contact with her mom who lived in Plano. The mom wasn't able to realize the state she was in. She came down here, set up some insurance policy to be able to get her connected to rehab. We did have to do a temporary detention on her twice to get her back hospitalized. But then we were kind of able to work all of those pieces together. And so she's now headed to Fullbrook in Fredericksburg. We also had another patient who really needed to be in a nursing home. He had the primary we needed. Family was not taking care of him the best way. He was getting discharged. He was in these boarding homes. They weren't really attending to him. He would come back and it was just a lot of cycling. And so we kind of used the AOT and the court as an influence with the family to kind of make those decisions and kind of get him where he needed to be. And so then he got placed, in a nursing home and his commitment ended and all of that. So I don't know, this happens all the time, right? Where we think we're getting one thing and then it's kind of another thing. So I just kind of, okay, what does this person need? How can we help them still access those resources? So.
You actually have admission criteria on a paper that you hand people or electronically give people? Raise your hand. So not all of you, okay.
And so I was going to say, you know, in Butler County, anyone who has been civilly committed at a hospital setting for inpatient commitment is automatically moved to outpatient commitment upon discharge. And the advantage of that is that we get everybody. And then we try to let the outpatient provider sort things out, using the court, using me as the monitor to try to sort it out. So if there's substance abuse issues, we address that. And for us, and again, I think the most telling point to make in any of these conversations is everyone's program is different. So what I say for us may not work for everyone, but for us, it tends to work out because we have some folks who, let's say, are admitted to a hospital because they suffer from bipolar disorder, they've gotten off their meds, they go to the hospital, they can get back on their meds. And for some of those folks, they may restabilize fairly quickly. And at the 90-day mark, their outpatient provider may indicate that they've regained stability, they've regained some insight, and they're going to continue treatment without the court oversight, and they dismiss the case. And then we have other folks who we've kept on for years. But the main point is that we do take everybody, and we do then use the outpatient process to try to sort that out. The only change we've made to that in my 14 years is that for people who are going from a hospital setting to a nursing home, where I know that they are unlikely to ever leave the nursing home, especially if they have a guardian, then we may not take that case. That's the only exclusion that we explore at this point. But otherwise, everyone else we just take. And so that's one option for a referral process.
And Summit County also does the same thing in Ohio. Anybody who's involuntary inpatient automatically becomes involuntary outpatient. And again, the treatment team sorts it out. And if they weren't really appropriate, then they don't get repetitioned at the 90-day mark. So.
I have a question about that actually. How does that work? Is there a default amount of time that they remain on that order outpatient? And then what happens? Is there a way for them to terminate that order, you know, prior to that default amount of time if they're doing well? How does that work in where you are?
Beth, do you want to use? Why don't you jump in and then I'll go after you?
If I'm a mute button. So what happens, as a matter of fact, I got a couple of them today. If the psychiatrist feels that the person that's on commitment is doing well and doesn't necessarily need to continue, doesn't need that continued observation, then they'll send over a form, I was looking for it as a matter of fact, to our ADM board and say, hey, we'd like to terminate Joe Blow. He's doing so well, et cetera, et cetera. When we first get them, when they're first committed, it's an automatic 90 days. So we keep that going, and surprisingly, that does go rather fast, don't you think, Nick? Yeah, yes. That goes pretty fast. But we too have had some folks on that have been on, it seems like, well, it has been for years, And ironically, I just received a notice yesterday that they are going to discontinue that person's commitment. And they've been here as long as I have, actually longer than I have. So it's up to the doctors. We throw that into the psychiatrist's lap and let them take that lead and send it over to our ADM, or Alcohol and Drug Mental Health Board, and then discuss and take it from there. It seems to be pretty effective. What do you think, Nick?
And Tara, so I think, yes, Beth's court and our court operate differently, but the protocol is the same in the sense that our civil commitments in Butler County are never terminated by the court. They're terminated by the psychiatrist report that recommends dismissal of the civil commitment. Okay. And so it allows me as a probate monitor in seeing people to say, you don't have to impress me. You don't have to impress the court. You need to talk to the doctor about treatment and insight, because it's the doctor that's dismissing the commitment, not me and not the court. Because we have some clients who will come in at 90 days, put on their best suit, and try to talk to eloquently to the magistrate and say, look, I should be off of civil commitment. But the psychiatrist report says, no, they need to stay on it. So by using that criteria of only the doctor dismissing the case and not having other criteria, not having a time length, not having a diagnostic criteria, but letting the doctor make that decision, then it pushes people towards treatment, and then they have to engage their treatment provider. But I find that to be very effective. Now, we do 90 days just like Beth does for the initial commitment, then we do every 6 months after that. There's a few differences, but that's how we do it. Now, if somebody at 3 months into a 6-month commitment, if the doctor says to me, they're doing well, I want to dismiss the commitment, I have them do the same report, right, and we can dismiss it early. Again, whatever works for the respondent based on the psychiatrist's recommendation.
And it's a good sell for your judges and your magistrates too. You know, if they're concerned about letting somebody go too early or anything like that, that falls on the lap of the psychiatrist. So that might be a good push to get your judges and magistrates on board.
Good point.
Thank you. Thanks.
Nick, how does the from the 3 months to 6 months, who is responsible for that? You said that it's originally 90 days and then it's 6 months after. Who gets the 6 months granted?
So everybody coming out of the hospital has a hearing within 90 days. And at the 90-day mark, I get a report from the treating psychiatrist at whatever agency they go to. In Butler County, we don't earmark people for a specific agency. They can go to whatever agency works best for them. I get a report, they go to court. If the psychiatrist says they need to stay on civil commitment, then the case is automatically set out for 6 more months. Then at the 6 months after that 90-day hearing, our prosecutor automatically files for an ongoing commitment. And she does that until we get the psychiatrist report that says to dismiss it. So we are kind of on an automatic rotation of continuing a commitment until I receive a doctor's report that says dismissed. And again, that pushes people to treatment. But for ours, it's automatic until that report.
Awesome, thank you.
Well, why don't we shift gears to another question, another topic that came up, and this is engaging, your partners. This kind of blends with the other issue where you've got existing partners that are transitioning. Either they've left office, or you've got a new provider, a new judge, a new district attorney. How are folks, addressing that? How are you reaching out to some of these new partners and getting them on board with your program? Anybody have any clever ways of addressing that? I know, Nick, you've had a new judge and a new magistrate just in the last few months. Any advice from you?
Well, the new judge and the new magistrate took over from a program that's been in existence for quite a while. And at this point, they've left our relatively well-working system in place. So that's been good. The new judge seems supportive. I don't have as much contact with him. Our new magistrate, who does our normal Tuesday morning ongoing review hearings, is incredibly supportive. She's an excellent magistrate and very supportive of our program. So we've been lucky in that regard.
Michael, I know down in Athens, Hocking, Vinton County, I know you're dealing with 3 different county systems and trying to get them engaged. What are some of the issues that you're having? Maybe some folks can help you troubleshoot that.
Right. So I know, as you know, like we have a new judge in Athens County since last November. The previous judge was not really open to having like any real fixed AOT program in place. And part of his interpretation of the statute still carries over into the current court. So with the new judge adjusting to his position and also kind of navigating some of his own like internal court politics, like we're just kind of waiting for a real full response from him on what his position is going to be, whether we'll be able to have status hearings or whether the behavioral health providers will just kind of have to take an approach of petitioning for outpatient commitments and handling it outside of the court beyond that. So, yeah.
So other partners, they may not just leave or transition out. They may be difficult to work with, or I know Kayla has a big challenge in the public defenders in the, well, they're not public, they're the guardianship attorneys who play that role. And at this point, I think they're probably one of the biggest barriers to the program working well at this point. I know you're new. What's just, actually, it'd be interesting to see what your new eyes have taken in on that.
Well, a lot of the interactions that I've had with them have been like a nice way to put it, just very restrictive on explaining why the program would be beneficial. They kind of make it seem like it's a ticket right out of the hospital using our program. Also, I think that I don't know for sure what they're saying to clients or how they're explaining our program to clients. And just getting them like in a timely manner. I think I'm trying to figure it out because I'm still like in the works of figuring out the whole program, but how it works is the paperwork has to get to them. They're like the third step in the process. And then it just takes a while for them to understand that if we don't have all of our stuff, then the patients get discharged from the hospital and then we can't, then it changes everything around for us where it goes from a step down to a step up. And then it's another process on top of that. And by that time, the patient's already checked out and doesn't want to be in the program because they've already been, discharged from the hospital and they would have to voluntarily be a part of our program. So the timeliness of them, and then also just the lack of understanding and being on our side in regards to why the treatment would be helpful, I guess.
Yeah.
It's kind of where I've noticed a lot of it. So I'm sorry, I'm still like trying to figure out the verbiage and everything.
No, it's all good. It's something that I think about all the time, and it's a big question. And I know that of all the people sitting here, they may answer it differently and they'd all be right. And that is whether AOT is voluntary. And I know that in Springfield, the guardianship folks think that it should be voluntary. And if the person doesn't agree, then they shouldn't have a court order, which doesn't make a whole lot of sense to me about the purpose of a court order. But does anybody have any thoughts on that? Especially some of our seasoned people? Wow, I just tanked the conversation.
I think at some point, there has to be some buy-in from the patient. They can be placed on the court order by doctor testimony and not be voluntary. But at some point, as you're going through that process, that responsibility's got to shift and it becomes sort of a voluntary thing, right? And then when we go to renew them after 90 days, we leave that decision up to them. So we're sort of shifting to full responsibility. And so then they are voluntary. So, but in order to engage in treatment, there has to be some buy-in. They have to get connected and feel like there's something they can gain from the program.
I'd just like to add, I think that's where the court order helps us, because a lot of our clients see that court order as, they have to comply and they have to do that. And where before, previously we might try and engage them in some sort of treatment and they wouldn't participate at all. But with that court order, it's kind of telling them, you have to participate. And our judge, at the beginning tells them, you have this great opportunity and I need you to tell me that you're going to at least try. You're going to at least, go to one meeting. And some of our clients do, some of our clients don't. I think Erica is completely right. It becomes voluntary. It becomes, involuntary. Because, our clients go through these ups and downs of AOT, and it's having that conversation with the entire team. And I completely understand, just having to have buy-in from not only your clients, but from your providers and your attorneys that you work with and your stakeholders. And the most important thing that I feel that we have in our program is we have constant communication with each other. We have a monthly meeting. We did a lot of work on the front end of the program. So we had a Stepping Up initiative where we brought in a whole bunch of different people talking about the different intercepts. We had our community, they really stepped up to that, and they volunteered to help with these different programs. And AOT was one of the first ones that we brought. And during this time, we had meetings bi-monthly. We had, before we even had a first client, I think we met probably 8 or 9 months bi-monthly to figure out everything. And then of course, it always gets blown off track when we have a new provider or somebody that doesn't completely buy in, or, somebody that's just, steps away from the program. So we've kind of become a, well-oiled wheel where we just kind of try and engage, all of the partners to come into our group and to provide the best services that they can. And it's just a whole lot of communication. We've brought Brian Stenton in down to over here to New Mexico several times to talk to service providers, to talk to attorneys, to talk to judges. And I will keep calling him and the TAC if we have people that are just not, do not want to participate, and it seems like, you know, that could be our weak link. So I really depend on TAC for a lot of the technical assistance and help in bringing us together, and just a lot of that communication.
You know, I view AOT as kind of like a three-legged stool with the respondents, the treatment providers, and the court. And I think the monitor's job is, and again, every monitor has a very different position. And so how you adapt what I'm going to say to a certain program is going to be different for each county. But the idea is to balance that stool in whatever way it needs to. And so I'm just thinking of a few examples. You know, this week I had a respondent who was telling me that he was oversedated from his meds, and I was able to communicate with his treatment provider, and they moved his doctor appointment up from August until early July so he can address that. He's a quiet guy. I don't think he was really being heard by his case manager and therapist. So I think I gained some buy-in from him by advocating for him in that regard. The same agency, and we use different agencies, it just happens in this case it was the same agency, was short-staffed because of summer vacation, et cetera, and a client was being discharged from a hospital to a group home, and they couldn't get someone to take them, and I said, I'll do it. So I gained some buy-in from the agency and had the client get in my car, and I drove him to the group home. And it was a great intervention because I was able to engage the respondent. Buying respondents ice cream in the middle of summer is a great way to gather some buy-in, but that's what I utilized. But that was a way for me to get buy-in from the agency. And then for every court hearing, I produce a report for the court. And as we all know, courts, whether they're probate courts or criminal courts, want information. In general, judges want good information. And as a monitor, I can provide a summary report for the court so they can read a one-page report and walk in and have a pretty good idea of what the respondent's been doing for the last 6 months. So I gain buy-in from the court by doing that. Now, again, everyone's going to adapt what I just said in a variety of ways, but I do think that's one way to engage all different partners.
Another strategy for some of the newer programs is just, you know, getting your partners to agree to a small, you know, just try it. Let's just try it with a few cases. You know, you don't have to commit to the long haul, but let's just give it a try. We'll monitor these folks, we'll monitor these cases and see if we're, you know, having some positive outcomes. Because once they start seeing those positive outcomes and they start to, you know, believe in the program, but sometimes it's just, you know, it's a lot easier to get them to commit to something small than to, you know, to embrace the entire program all at once.
One of the other things I did early on was just make sure that I was touching base with the hospital again, you know, as to how they were doing. Because sometimes it's like that handoff hospital to us, and then they get busy, they forget. So I would call them and remind them, remember so-and-so, you know, they're doing really well. This is what's going on. This is what they did. They had their injection or they did whatever, you know. So I'll kind of do that to kind of remind them, and then they might stop and think, oh, we haven't seen them in a while. They must be doing good, you know. So like using that, just continuing that communication.
That's such an important point. Yeah.
And that is brilliant. You know, your referral sources, unless they're involved in the client's life, aren't going to know the successes. And of course, the more success you have, the more likely they are to refer. That's brilliant. And I also want to say kudos to the ice cream intervention, always appreciated.
And I don't want them to eat ice cream alone, so I have to get one myself.
Wow.
It's a giving job, but I try to do it.
I do want to ask, and I don't know, Amy, I know you put together some poll questions, but I am curious to know, either we can ask a poll or just a show of hands, but are you keeping track of these success stories? Are you documenting examples of these? Because I think they're imperative in terms of just sustaining your program. And like, Erica shared, that's a great use of it. But if nothing else, even at your quarterly stakeholder meetings, to be able to have, 2 or 3 examples of success stories on hand. Oh, here we go. Oh, that's great news. Okay, 73%. Good. So next time we ask this question in 4 months, we're going to get 100%, right?
So one thing I've done in the last 3 to 4 months is that whenever we've had a respondent be dismissed from commitment based on their success in treatment and their demonstrating that they will voluntarily continue treatment without the court order, is I've sent an email to the agency, generally to the supervisors of the case managers, et cetera, discussing where the respondent was at the start of the commitment, how well they've done now, how their doctor has recommended dismissal. And I've been amazed at how appreciative the agencies are to receive positive feedback, because as we all know, so often agencies only get the criticism and the complaints, et cetera. And so I've made that part of my program, is to make sure that every time a respondent's been dismissed, that I report that, not just by sending the court entry to the agency, but by sending an email highlighting the good work the agency did to get to the respondent to the point where it can be dismissed. And the 5 minutes it takes to send the email gets me a whole lot of buy-in with the agency, and they deserve that credit, because they have done a nice job of getting their clients to the point of being dismissed. So that's been an effective tool for me.
But you don't buy them ice cream.
I'd go broke if I bought them all ice cream.
That's true. You've got a big program.
Got to be a little judicious on the ice cream. Plus, I'm eating too much ice cream in my day anyway. I got to watch that too.
So if I could just say something that's a little bit off topic, but I have to hop off for another meeting, and I just wanted to leave with, one of the things that I just really love about this program is that so many of our people have been through trauma in regards to mental health. They've been detained over and over again, systemic trauma with their families, and I feel like this program is such a supportive and loving and caring sort of program, just kind of guardrailing them to treatment, that they're getting an opportunity to learn that there's a way to be with the court system that doesn't have to be traumatic. There's a way to interact with law enforcement that doesn't have to be traumatic. And they can heal some of that. So I just would like to leave with that, because that is the thing that keeps me going every day with what I do. So.
Thank you for that, Erica. And just real quickly, before we leave this topic, in terms of success stories, if you have a participant, and I know a few of you have had over the years, a participant who really comes out of the program, really has turned their life around, and they're wanting to share their story, we can certainly give them a forum at the Treatment Advocacy Center. We have, an opportunity. We've got an excellent communication staff that can kind of help them write that out if that's something that they want to share. Those stories go such a long way towards promoting the program. And I think people like, want to be able to share their story. In some cases, it makes them feel like they're giving back. So either a family member or an individual, feel free to put them our way, and we can, we'll take good care of them and make sure that it's done in a, professional manner. So just kind of keep that in the back of your mind. Sarika.
Thank you.
Interestingly, when we were going through the list of challenges that you're all facing, I was eager to see if anyone was going to bring up working with families or engaging families, not necessarily as a challenge, but just, just as something you might be struggling with, or you have a way of engaging families that others might not have thought of. So I'm wondering, maybe we could put that on the back burner, but we'd love to find out who's having success in that area, and anything you're doing that might, others might learn from. If you're having or if you're having an issue with that, and you want to bounce some ideas off maybe for our next meeting, keep that in the back of your mind. Be ready to share on that topic if you would, because that's something that we hear a lot from programs, on that topic, either positive or maybe not so positive. So. Amy, did we have another poll question we wanted to ask, but we've got everybody?
We can. I've been sharing this whole time. Y'all need to remind me to take that down. The other one, and this is another topic that we're interested in learning more about how your programs work, and that is data collection. So here's the quick poll. Oh, good.
Oh, wonderful. That's great. Perfect. So are there other things you all want to talk about? We've still got a few more minutes together. I know we've lost several in our group at the top of the hour, but if there's anything you want to share or have a nagging question for the group. And if something comes up after, we don't get together again for another 4 months. But if something comes up in the intervening time, you have a question you'd like to pose to other AOT monitors, we have the ability to kind of put a question out to the group. So never hesitate to reach out, or if there's somebody you want to connect with afterwards, we can help facilitate that. And I know several of you, raised concerns about, dealing with engaging some of your systems partners. We can also help coordinate if you've got an attorney who just doesn't get AOT and would like to talk to another attorney from another jurisdiction. We can help make that happen. Some people, like to talk to their their peers. They don't want to hear from somebody who doesn't know what their business. So we're happy to facilitate those connections for you. We've got several judges who are happy to make calls to other judges if you think that would be useful. And I think our next meeting in July is with the judges. So if you can encourage your judge to participate in that discussion, that's always useful too. And even, if you've got a judge or who's not really sure yet that they're, whether or not they want to participate, it's often, those are the ones that would really benefit the most from those discussions, I think. So they don't have to be actively doing AOT in order to be on that call.
And not only can we hook you up with peers to stakeholders, we're also here for you as well. So never hesitate to reach out. to us if you have a question or concern, and we'll do what we can to assist.
Well, thanks everybody for your time this afternoon. We'll see you soon. Enjoy the rest of your day.
Have a good summer.
Everyone.
See you.